going to join us. Frimpong. And Frimpong says as well, Thomas says as well, he didn't get the link. Can you as well send it to him?
Yeah, I'll resend it to him.
Now, does anybody else has cases you want to discuss? I have a lots of cases we can discuss, but does anybody else has any cases that you want to discuss? No takers? Okay. Then let me just start with my, and I have over 120 pictures. We won't get through all of that, but and I would say, we should put a limit on each picture because I want to go through lots of things that is specific to what we do. And then I wish Sam was here. Sam says thanks. Okay. By the way, Sam and Dr. Goyal and Dr. Jimenez, I'm not sure I think he might be on call today. There are as well other people that are joining our group. So we are already a national group of people. So let me start with, and we are just going to go easy on this, okay? So it's getting recorded, correct?
Correct.
Okay, here. Okay, tell me when you guys are ready to see me.
I can see it.
I can see it.
So is was it Scott? Scott, is this you?
Yeah, he's on. Scott's on.
Okay, good. Now Sam is on. Farbod is on. Frimpong is probably cannot join. Now, Sam, our societies, what do they say about elective spinal fusion and BMI?
Funny you asked, actually. I just submitted an abstract, a QOD abstract for a 5-year research on low-grade spondy and BMI. Basically, we didn't find much difference, but at 5 years, we found that people with higher BMI above 35 tend to have lower MCID, minimal clinically significant difference in the VAS back pain, but they improved with leg pain. But what happens in our society, basically, like we tend to refer them to someone else, basically, to or advise them about bariatric surgery.
Well, Farbod, you're familiar with the NAS and AANS recommendation regarding BMI and elective spinal fusion.
Yes, I think you don't want to do surgery based on that recommendation in a BMI over 35.
Well, actually, I think some say 35 and some say 40, but the overall consensus is for elective traditional spinal fusion risk versus benefit is not justified for BMI above 40. That makes half of my patient. Yeah. Literally half of my patient are BMI above 40. Now, this is a patient that I have been actually following for almost 2.5 years. Ken, do you want to tell us why I have been following? This patient's BMI is 54. I have done BMI of 64, just did it 2 months ago. I did the surgery in 1 hour. The next day, patient was singing Amazing Grace before she flew back from Kansas to North Carolina. And if you would see him next day, now this patient did not go to ICU. This patient did not have a 12-hour surgery. This patient not this patient. I mean, the patient I did in Kansas, BMI 64. The information is there. Mitch, if you have the statistic of that patient, can you get it for us while we are talking? So we have a good track record being able to do BMI 60, 62, 64. I mean, these are massive patients. So we have been able to really perform the surgeries on this group of patients. But on this specific patient, I had to wait. I couldn't do surgery on this patient. Ken, do you want to tell us why is that?
Well, the instruments needed to be longer. The access portal just wasn't long enough to reach at the current stage of 8 inches. It wasn't long enough. So we're
Yeah.
extending it out to a system that has 9.5-inch access portal.
So right now, yesterday, actually not yesterday, it was yesterday I had surgery, but the Thursday, and I had clinic. 1/3 of my patients were a patient from all entire United States, high BMI. This patient go to surgeon and they're told rightfully risk versus benefit is not in favor of doing surgery. So they come to me from entire US, and most of them I can do the surgery. On this specific patient, the entire weight is on the hips, as you see, and that my access portal is just not physically not long enough. Now, that is the point I'm trying to make. We published a paper in when was that obesity patient, John? Was it 2017 or 2018?
That was 2018.
2018. So where we compared 3 groups, MIS, TLIF, and OLLIF patient regarding the BMI. Obviously, it makes sense that with the TLIF, when you go high, after BMI of 40, the surgery becomes a massive surgery. Now, interestingly, I'm happy you mentioned about the BMI of 35, because in MIS TLIF at BMI of 37, there's a flip. In that study, the surgeries that were done on a BMI above 37, MIS TLIF was riskier than regular TLIF. This is one study, but still the result is that. But OLLIF stays flat. We could do in that study, we could do up to BMI of 54. In a follow-up study, we have even included BMI at 62.5. That was the highest I had done at that time. And now we have done a BMI of 64. Now, the beauty of it is once the tube is in, it doesn't matter if you go through 2-inch or 6-inch of fat. And as you know, it is a mathematic of it is that when the radius increases, the volume and the mass increase power 3 cube. It's cubed. So meaning that adding going from 1-inch fat to 2-inch fat, you are going up tremendously. The BMI and the whole weight and the so on goes tremendously. But our study could show that as long as you get good pictures, and that is the key.
Yeah, that I think is the problem sometimes, right?
Yeah, as long as you get good, but we have an extra. Mitch, get the link to our BMI and X-ray. How in one of our Facebook, there are lots of tricks you can do to get good BMI. Obviously, good machines is one of them. Setup of the room is one of them, and then distributing the mass. One of the problems is here the pancake. If the pancake, then these machines, they just don't work well anymore. But if you distribute the mass and make it as round as you can, tape it, that's what we do. You tape it, then the machine do actually pretty good job in doing that. Now, Sam, what is the highest BMI you have done in UCSF or you have seen them doing in UCSF?
A fusion, we
Yes.
did like 41 one time.
41.
MIS TLIF, yeah.
41.
Yeah.
So 41 is like a candy for us.
Yeah.
That is like, now, one of the things that Farbod, what is the highest that you have been seen in the university setting or yourself, highest BMI that for multi-level spinal fusion you have seen or done?
I would say it's probably less than 40 for sure.
Yeah. Well, once you come and see how you do that, it's really no science to it. This is the process. You get a good picture, and like the patient we did in Kansas, 3-level. We did a 3-level OLLIF, and the other one that I had done before, 62.5, that was a 4-level. That patient was 500 pound, came from Cleveland. That patient was so massive. Our surgery was less than 2 hours. Our blood loss was less than 100 cc. But that patient still, after 2 hours surgery, anesthesia still couldn't extubate. They just didn't feel comfortable. They kept that patient one night in the ICU, extubated next day, but the second day that patient was discharged. 4 days later, flew back to Cleveland. So it is doable. It's a process. You just have to, pay attention to get a good CT, understand what you are going to do, good X-ray in the surgery, and distribute the weight. The rest is you just repeating the same thing. Now, for this patient, because most of the weight is in the hip, I just didn't have the long enough of an instrument. Now, this patient lost, this is a picture I just took a few days ago. This patient already lost about 70 pounds. Now, I took the patient in the CT, I put a long spinal needle. Now, on regular, if they come back to you, this is the patient that have been complaining that it takes so long. Now, the regular tubes are long enough because she did lose 70 pounds. That 70 pounds is just the difference between, am I able to push that tube into the disc base or not? That's the only thing. But with the, so I'm expecting with the 9, what is it, the new length, Ken, 9-inch?
We're going to 9.5 inches.
9.5 inches. So that should be truly enough to do, I would say 99.9% of the population in the United States should be good enough to provide them with the option of OLLIF. Now, so we have a lot of other pictures to look at. Any comment or any questions regarding this? So what is our timeline for 9-inch tube, Ken?
I believe we're planning to launch in April.
Okay. Very
So
well.
I have a comment about these, fat folks. I mean, they tell us they get fat because they can't move because movement hurts, and so they're not active, and then they gain more weight, and then the activity hurts more. So there's this downward spiral.
Yes.
So this is great that you can fix them.
Absolutely. Univariously, they tell me the same thing. They tell me the other surgeon told them, go lose 150 pounds, and they come back and they have gained 100 pounds. That is exactly what happened for every single of them. And, this is, okay, let's put it this way. I am myself trying to lose weight now for so long, just few, like 10, 20 pounds. I know how hard it is. It is truly not just the pure will, because some people who have the genetic of like David, you are so blessed, but part of that is genetic, part of this microbiome, part of it is where you grew up. But for people who are that like him, or they have anabolic metabolism, it is hard to lose weight, and it is even harder if you cannot walk because you are in pain. The only joy left in life, you sit on the couch and eat more. That's the only joy really left. So, but I have as well a lot of track record. Once I do the surgery, not everybody, but many of them, majority, I see them 1 year later, now they have lost 50 pounds, 70 pounds. And so because they can walk, see, they are disadvantaged to start with, but now if they cannot walk, then it becomes disfavorable. Now, if you put them back on their feet, it becomes a little favorable. They will never go back and look like you, David, but
well, and I mean, there's also this reinforcement of physical activity enhances the not neurotransmitters, but like dopamine, norepinephrine, serotonin, all these things feel good when you can get up and about and move. But if you can't do that, then food does the same thing. So it becomes a nice replacement.
Sugar is the hugest source of epinephrine, and those the high sugar make you high. That is we know all about that. Okay, that's why they sell it so easy. Okay, so you're absolutely right. Now, having said that, nobody ever doubt. If you look at the films of these people, nobody doubt they need a surgery. Nobody just nobody wants to do that. Now, Mitch, actually, last time you were in Kansas, what percentage of this patient were BMI 45 and above. You remember you and I, we asked that. I think 60% of these patients were BMI. That's one of the reasons we are growing so fast. We can do these cases so easily compared to other people, and they come to us. That's why we grew 700% in Kansas and about 300% every year in Minnesota, because truly we are the only hope these people have. We can do it safely, we have a good track record, and it's not person dependent. Dr. Kim does, for God's sake, BMI of 55, 60, and he has done maybe 1/4 of my number. So it's a process, not a surgeon. Having said that, you have to absolutely be prepared for this patient. So, Monica, what do I mean? You have to be prepared for this patient. What do you think? We do a lot of them in Riverview. What do I mean you have to be prepared for this patient?
Well, I think, just even getting the room prepped, getting them on the table, making sure that, you've got everything you need when you're good before you do the surgery. But then, even afterwards, you have to watch for complications like DVT, pulmonary embolism. You want to make sure they're getting up and moving around. I mean,
so you're absolutely right. Just moving them from stretcher to the bed is a big deal.
It is.
Your team need to know what are the steps, what you're going to do. You cannot guess.
No.
Once you start moving them,
right.
If you're not prepared, you're screwed.
Yes.
The whole mass will be in wrong places, and forget about it. You have to have a plan. But all of that is steps that you can learn like anything else. If you can do that, Sam, you're the only person in the entire Middle East that can do this kind of cases in Lebanon, and they will come to you. This patient have no other choice. They will come to you. Now, and the process, once you adjust to the process. Now, another thing is, you are absolutely right. Now, let me tell you, in University of Minnesota, what if they have to, they never do that, but if they have like 40, 45 BMI, these patients stay a week in the ICU. This patient surgery is 8 to 12 hour surgery. They lose half a gallon of blood. And now, in comparison, we do that surgery in 1.5 hours for 3 level. We lose 100 cc of blood. They walk. 90% of them, if they're extubated, they walk same day, and they go 9 out of 10 times home next day. This is statistic that we have gathered in the last, not 3 months, in the last 10 years, that we are able to do that. I think other comment, if you are going to go with this period, I can only show you 5 pictures, but is any other comment, anything else you guys want to know about this case or similar cases?
Seems with us, I just did, we're not doing these big fusion surgeries, but the other aspect of these surgeries is engagement with your anesthesia team, because they'll look at this and just say no. So sometimes you have to find an anesthesia team that is maybe experienced, and after they do 1 or 2 of these, then they sort of get more comfortable with it, and they kind of figure out what they can do, and they can help facilitate.
Absolutely.
Or they can block it too.
No, and they should. If they think so. Let me tell you a story. I had a patient, BMI not that bad, 54, no, 52 actually. I'm sending the patient to the university. The anesthesiologist come and say for 3-level fusion, and the patient is telling the anesthesiologist, that my doctor said this is 1.5 hour surgery. The anesthesiologist violently shaking her head and saying, no, this is an 8 to 12 hour surgery. You stay 4 days in the ICU. Probably the first 2 days we have to, put you on the machine to intubate, to ventilate you, and so on. But then once he called me, once we discussed that, listen, this is not what you are used to, regular surgery. Here, look at our track record. We have done it. And now that surgery, actually, I did take the patient to another hospital, and I did that surgery in Mitch. Can you know which one patient I'm talking about, right?
The biggest one, or which one?
No, the one that I was going to do in the university, but then took to Crookston. No.
Oh, yes. Yep. What about him?
No, can you get the statistic of that case as well and present it to us, please?
Yep, I'll pull it up right now.
Okay, so yes, absolutely. You have to talk to anesthesiologists. You have to have them on board. They need to know what you are going to do, because clearance for a 12-hour surgery in this patient is different than clearance for a 1.5-hour surgery. Okay,
Yeah,
Mitch,
that's exactly what we run into a lot, actually.
yeah. Now, Scott, this is the case that you and we want to discuss here. Because I know you're a master of this sacroiliac joint trident fusion as well.
I like it.
Now,
I don't remember this patient.
Yeah, no, this is the patient I just did. No, I don't believe this is your patient.
Okay.
But what is the specific thing about this? I mean, do you want to describe the anatomy here to me a little? And
I was looking at this, and I would say that the sciatic notch right here. Did you?
Was this exactly the point I'm putting it in? The sciatic notch is not
quite
clear. It's not quite clear.
Yeah,
that's exactly the reason I'm putting in. So now sacroiliac joint is the highest number of increasing surgeries in musculoskeletal, and it's going to grow. The orphan child of musculoskeletal. We surgeon, we have been neglecting it, and then some of us just being, excuse my French, being total dicks, we accuse the interventionalist to helping the patient. So that is why, thank you, Scott, for what you're doing. This patient truly needs help, and every single of them, they come, they stand up, they hug me, because they have been told for years there's nothing wrong with them. You and I, Scott, we do a 20-minute, 30-minute procedure. Their life really changed. Statistically,
I see that. At least in my fellowship, we would treat facet joints as pain docs. If this facet joint didn't provide adequate pain relief, we then went to the sacroiliac joint, because the overlapping referred pain pattern is quite significant. And I mean, since 2012, I would do these sacroiliac joint injections, and I had all these patients who would get great relief for about 4 hours, but not durable relief with an intra-articular sacroiliac joint injection. And then we didn't have anything else.
The knowledge is not new. The knowledge is not new, Scott. You just mentioned that. So, you do can you describe your process of you said you inject and so on. Can you describe your diagnostic?
Well, for me, in my hands, this is probably the most invasive thing that I do for patients. So it took me a little, from a pain physician perspective, it took a little bit to wrap my head around actually doing this. But as I started to think of the biomechanics of the sacroiliac joint versus what other things could be offered, like a lumbar spinal fusion surgery, with a lumbar spine fusion surgery, which many of these patients would get at the drop of a pin, nobody would think about it, because they also have things going on in the lumbar spine usually. But with a lumbar spine surgery, you're taking a mobile structure, a structure that's supposed to be mobile, and you're immobilizing it, hopefully for a greater good. But it also introduces a lot of abnormal biomechanical stressors into the spine, which we think may contribute to things like adjacent segment disease and this escalating ladder fusion that we hear of. If the sacroiliac joint, however, is the true or more significant pain generator, when you fuse the sacroiliac joint, and I always preface when I tell a patient I'm thinking about fusion, I just acknowledge that word has a very bad connotation when we say fusion. But the difference in the sacroiliac joint is you're taking a structure that should be, for all intents and purposes, immobile. You're not destabilizing it. You're not taking out bone to destabilize it and putting in screws to stabilize it. You're just supplementing the stabilization that already exists, but might not be as effective as it should be from perhaps loose ligaments or extra pressure if you've had previous spinal fusion surgery. So that's how I explain to patients. I don't like to the patients that I look for are patients who have kind of axial back pain. Sometimes they have pain that goes below the knee, but I'll certainly do the Fabers, the thigh thrust. I'll do SI joint compression, and I can do that. I mean, I could do what I call a quick and dirty exam in the room without having them to disrobe and do a whole bunch of things on the table. Then I have physical therapy, do other things like Gainslands. So I look for that. I will invariably want to at least see if there's anything I can do for the facet joints. So I'll try a medial branch block, and I'll try radiofrequency ablation. If that takes care of their pain, then we do that every 6 months and we're done. But there are many patients who you do that for, and or in the older population have fused facet joints anyway from lumbar spine surgery.
Yeah.
And then I'll proceed to a diagnostic sacroiliac joint injection, and I do my best to get a very, very nice like dye spread. I've worked really hard to try and get those very consistent. Sometimes it's not.
It's a hard injection.
It is. And every time I see somebody, I ask them how they do it, and I've gotten some tricks that I'm getting more consistent with it. Now,
do you do your injection in the inlet view, AP, or outlet view? How do you do your injections?
Well, what I'm starting to do is look for the junction of the PSI. So I do a contralateral oblique view. I don't necessarily do inlet or outlet, but what I look for now is a white spot, which means that the beam is going through nothing. There's like no
air or
yeah, it's just air. Yeah, it's joint space. And sometimes it's very small. And if I can find that white spot, often it's right below the PSIS. Sometimes you'll see, you have to look, I didn't think about this, but the PSIS is a little bit high. And sometimes you see a white spot, but if you see the PSIS overshadowing that, you're never going to get in because the PSIS will block your needle entry.
Yeah. See, the boomerang or the articular part of the joint should be your target based on recommendation. But to get from the back to the articular part, you have to go through the ligamental part of the joint.
Yep.
And even if you see the white might be actually in the iliac, somewhere covered by the other areas.
Yep.
So it is hard to get. Now,
and I mean, there are many different. I mean, sometimes another spot is to try and go posterior and inferior. I mean, always posterior, but inferior.
Yeah.
Sometimes that works for me. And then the other aspect of this is, I've developed there's a tactile sensation when you're in the joint. It's if my needle is rubbing against bone, then invariably I'll inject and it looks vascular. But if I feel it's like your needle's going through a rubber band or something, and then sometimes, and one of my rad techs will call it the hiss of success. Sometimes you enter the joint and you hear this because there's a vacuum there. Then I know that I'm going to get a really good arthrogram.
Yeah. Now, one of the tricks that I use the TUI needle, not a regular spine needle, because this edge, the tip of it is not super sharp and it doesn't get hang on the bone.
Well, that's an interesting thought.
Yeah, I don't go completely to the outlet, but a little more than somewhere between regular AP and outlet, and I do angle it a little like almost not quiet iliac crest view, just a little. So you see the bottom, the only place that is really exposed of the articular part of the boomerang is the bottom part of it. So if you go to quiet outlet view and then a little toward the iliac crest view, that part is the part that is more exposed. And then what I do, I put a little bit of a bend as well in the front of the TUI needle.
I always bend my needle. Yep.
Yeah. And then when I'm going in, I just turn around a little back and forth.
Yep.
Until it, this is a low risk but high complexity injection. Now, Sam, Bob, Farbot, and everybody who does spine, if you don't include sacroiliac joint, you don't have to do it yourself, but if you don't include sacroiliac joint in your practice, you will have a lot of unhappy patients, because we know 1/4 of the spine back pain problem people are coming to you is not spine, sacroiliac joint, but once you fuse them about 43% of the time, if they ever come back to you after spinal fusion 455S1 and they still have back pain, it's not their spine, it's at their adjacent segment, which is the sacroiliac joint. Now, you help them, you will have a happy patient. You do not help them, you will have failed back syndrome.
So for me, the patient that comes in that has ongoing back pain and has already had a spinal fusion surgery, then it's almost invariably it's a sacroiliac joint.
43%, this is almost half. So you're right on, Scott. You're right on. 40, this is this. Okay, I did not come up with this statistic, but it is a statistic out there. We can send you the references. So they come back. So since I have been including this heavily in my practice, my rate of failed back syndrome is 1/5, 1/6 of what it used to be. Because for God's sake, it is not failed back syndrome. It is the adjacent segment. Let's talk about this picture. God, I'm going to go through structure, or maybe for the younger people, tell me what I'm pointing to, and let's talk about it, because you have to understand. And I want to as well talk about why I'm showing you this picture. You mentioned it, the static notch.
Yeah, so in this, I mean, what I focus on mainly here is the sciatic, is lining up the sciatic notch.
Sometimes it's not easy because it can be asymmetric.
A little bit. I mean, so you want to get it as good as you possibly can.
Right. What is this?
And then you're looking for, promontory and the alar line.
No, but what I'm pointing here. No.
Well, to me, that looks like the L5S1 interspace.
Correct. Now, that is what you have to distinguish, that do not confuse this. This is the L5S1 disc. Now, Mitch, what is this?
What's that?
Can you tell me what is this?
The line going across, not the end plates?
No, this is the end plate of the S1.
Yeah. I'm not sure what that line is.
Okay, who wanna chip in? What is this?
Call that the alar line.
That alar. That alar
Yeah,
of
the
the
alar line.
sacrum. Okay. Now, if you move it back and forth, you will see there are two lines. They eventually become one. And you want, in a regular case, to have the best alar line and the best sciatic notch. Pelvis is has the most variability of any structure in our musculoskeletal. Sometimes it's just not possible to align sacroiliac, the sciatic notch, and alar perfectly. I usually, in those cases, choose something that is the best of both worlds.
Trying to get both.
Okay,
yeah.
now usually you don't see it as good, but
This one's very good.
Monica, can you tell me what is this and this and this? Is Monica with us still?
Yep, I am. So is that the interspaces between S1 and 2 and S2 and S3?
Correct. That is the rudimentary disc. It's 1, 2, 2, 3, S3, 4. Now, when you're doing this surgery, delete from your mind S4 and S5. Pay attention from S1, S2, S3. Obviously, vast majority mass of the sacrum is S1, S2. And the aim, if you are going to put multiple screws, going to be usually 2 in the S1, 1 in the S2. But if you are doing trident, aim for the rudimentary disc of the S1, and the other screws, they go up and down. Now, here, see, I just couldn't align the sciatic notch perfectly. So in a case like that, Scott, this is the learning point I'm trying to make with this. You see the parallax of the
head of the femur.
You go to the CT, that's why I always get a CT. You look at the CT. Is in the CT, is pelvic symmetric or not? You have to assure that because it is not given. But if it is symmetric, you have still the parallax, meaning the one that's closer to you is bigger than the one is further from your source of the X-ray. But more or less, that you can use as well the head of the femur. So here is not my final pick, here, because I just couldn't, sometimes it's bad, sometimes it's something else, sometimes the patient is big. But you can additionally, once you look at the CAT scan, you know pelvis is symmetric. You can use the head of the femur as additional information to align the pelvis for the true lateral view. That is how you start. In a true lateral view, you're going to, your starting point on the iliac crest is going to be about 1 millimeter or 2 anterior, the shadow of the sacrum, because first you have to pass through the iliac crest, then you are centered on the sacrum. If you start here, by the time you pass the iliac crest, you will be way posterior. Okay, so if you are going to for 3 screws, you start literally here, here, and here. The trident, you put it just at the S1, S2. Now, some trivias. What is the weakest part of sacrum? Is ala. Ala is the weakest part of the sacrum. So try to not exactly put a screw in the ala if you can. Okay? What is better is actually the screws in the S2 is better now because it is denser. For some reason, it just seems to be denser bone.
Yeah, so I mean, my spot is I usually try and get just anterior to the sacrum, just below, just a little bit below the S1, S2. I mean, for my first K-wire, just below the S1, S2 vestigial interspace.
Yeah, and there is only one wire. With the trident, you put one wire, then you align it, and that's why it's important.
I think that's the beauty of it is that I mean, this takes up the bulk of the time for the case, unless there's some other hardware issue that goes on later. But if you get it right, then the rest goes very, very quickly.
Done. Once your wire is in, you're 4 or 5 minutes out of Mitch. Number 1, we did 3 sacroiliac joint last Wednesday. What time we did 3 sacroiliac joint fusion? What time were we done? Do you remember that?
Yeah, we were done at 10 o'clock.
10 o'clock. It took us, in average, how long to put those by the way, Scott, thank you. I wasn't daring to do it awake, but now I'm doing, because you pioneered that, now I'm doing my sacroiliacs awake. So
you're not awake, you're doing MAC, right?
MAC.
So you're not intubated.
I'm not intubated. No, well, for a surgeon, that is awake,
I mean, we call it, I mean, for us, it's probably, and again, that's why I was talking about, even in your other cases, having engagement with your anesthesia team for those heavy cases. I mean, that makes all the difference in the world.
Yeah, but I have done 250 of that before I start doing one awake, because as surgeon, I want a patient to be gone. I don't want to deal with that. But looking at your experience, talking to my anesthesiologist, that opened my horizon. Thank you.
It takes some comfort. I feel like in other countries, maybe they don't do general as often. Like they have anesthetists that are more comfortable with the patient being a little bit lighter. But anyway, yeah.
Well, Mitch, how long did it take us to do these sacroiliac joints, skin to skin?
We did 2 of them in 12 minutes, and the third one was 13 minutes.
Not that fast, but I'm like 35, 40.
Well, that is the difference is I have done like 300 of them. That's just a number. It will be there. It will be there for you, Scott. Don't. It's not about 13 minutes.
I'm okay with 35, 40 minutes. That's not bad.
No, that's very good. That's very good. But but now, because I'm doing them awake, the whole procedure from the beginning to the end, from the patient coming to the room until patient leaves the room, is half an hour for us. Because we are not putting the patient sleep and so on. That makes a huge difference.
One thing that's taking a little bit of time for me is I'm not very good at just identifying the area I need them to clean without doing a pre-op image. So I got to get better at that. So I go in and I take an image before they drape, which takes extra time. I feel like if I can skip that will reduce my skin to skin time is going to be my skin to skin time, but my total OR time would be less.
And your skin to skin time will decrease. I guarantee you. I do that research on everybody. it is going to decrease, and that's just ways. But one of the things is going to help you decrease it. If they, you know, they have lots of gas in the rectum, all of a sudden you don't see the iliac, the sciatic notch. Once you have some other tricks, the patient is bigger, you know, the image quality is not the best, and so on. Once you overcome those things, then everything will become smoother here. Like you see that one of the reasons here, there is some maybe irregularity, it's not symmetric, but as well there's a lot of air in the rectum, and that sort of makes the interpretation harder. So, but coming back to that, especially Sam Farbot, as well, I see that Dr. Zager is with us today. Now, it has to be part of your repertoire, either yourself or somebody else, because you will have a lot of unhappy patients if you don't include that, okay?
You know, some other things that I've varied a little bit since I've worked with you, I make my so I find the middle of the sciatic notch, and I make my incision a little bit lower than where you are, so that I can continue to get my K-wire like in the, I want to go anterior posterior direction. I want to work up.
Yeah.
And then it does take a little bit. I think the other skill that's a little bit that you have to get used to is once you get, I mean, getting your K-wire to the right spot, and then I like the idea of using the blunt end as a placeholder, and then putting your dilator over it, holding it, and then going back to the sharp end before you enter the iliac crust. But it does take a little bit, it takes just, I don't know, Dave Schultz would call this fiddling, but just a little bit of fiddling to get it to stay there, because it will slip off the iliac crest sometimes. I don't know, sometimes it grips and sometimes it just doesn't.
So the reason you're doing it textbook, now what that means is that we start with the number one, it's not a really it's officially not a K-wire. It's not a Kirschner wire, because Kirschner wire is the 1.5 millimeter or 1 point something, but this is thicker, so it
Guide
is more
wire?
yeah, it's a guide wire. But
Sure.
it's a K-wire, whatever it is. It is more stable than a K-wire, but still it has some bend to it. Now, the only artery that I'm concerned about is the supragluteal artery, which is about that area. Hopefully, you are not close to that. Yes, our recommendation textbook is using the dull end within 2 centimeters of your target, and put a small dilator, which gives it stability. Then you put a small dilator that right where you want to be, then you turn it around, and then you put the sharp end, and then you hammer it a little in, and it stays in. So the reason I don't want to go with the sharp end, because supragluteal artery comes here, but then after that, where it goes is anywhere. You don't really know. I don't want to go with the sharp end and then scratch the sharp end around here. I have done over about 300 cases. I had one injury, pseudo aneurysm of the supragluteal artery.
Oh, wow.
Okay. Well, yeah. I mean, it's a traumatic. You injure it, and then the blood goes in the thing. I had to send the patient to the. So I see you see that there, Scott. I do all those mistakes that you don't have to. Okay, so you don't have to, and that since I have been doing this technique, had 0 injury. Had one when I was doing it the way they taught me, which is go with the sharp end, put it there so you don't have to fiddle around.
Great.
But the advantage of fiddling around is that with the dull end, you can hit that artery as many times you want. You are not going to do damage. But then once that you are within the vicinity, that vicinity is within 2 centimeters, you put the small dilator to hold the trajectory, then you put the sharp end that then you hammer it in exactly here, and that can hold the space for you there. Okay. Now, Sam, you wanted to ask a question. I apologize. Go ahead. You want to say something?
I think you and just my question is the first time I'm looking actually at your SI cases. You just do the whole procedure onto this view, or do you change the X-ray view?
Scott, do you want to go over the procedure after we get the lateral view?
Yeah, so I get purchase, and then Then I usually will go to the inlet view, and I guess different. So I've not done other systems, but I'm told that the guide wire for other systems, you're sort of coached to have the guide wire be parallel with the floor of the pelvic floor in the inlet view. But with Hamid's system, and it actually makes a little bit more sense to me that the guide wire is orthogonal or at a 90-degree angle to the sacroiliac joint.
Okay. Now that we are going to talk about it, I think maybe we should spend a little time here, if you don't mind. Now I was way too ambitious. This is the second or third picture we are looking at. I had like 120 pictures for today, so I don't believe we are going to go over all of that. Now, Sam, we can do another setting for just sacroiliac joint, or I can spend the time. We have another 10, 15 minutes. Talk about the sacroiliac joint. What's the consensus? What do you guys want to do?
No, we can look at the cases you prepared. It's fine. I'm happy to look
but
it
it is done in a very algorithmic way of doing that. It's literally you start in a lateral view, and then you start the entry point, and then you go to inlet and outlet pelvic views.
Yeah.
And then once your first screw is in, if you have a different system, then you go back all the way to the lateral view, start it all over 2 or 3 times.
That sounds so painful to me.
But that is the reality of it. Okay, now all the medial to lateral system are done. You know, we just know they don't work as well. Medial to lateral, I mean, where you go inside of the joint from medial, from back. The lateral to medial approaches are the way to go. Everybody's getting on board on that. And there is 2 ways of doing lateral to medial. True lateral to medial, like SI bone, or perpendicular to the joint. The perpendicular to the joint is not a true lateral to medial because the joint is not really in the plane, in our sagittal plane. Okay, so and in all those the lateral to medial that are perpendicular to the joint, you come at an angle to the actual. You're not exactly lateral to medial. You're
but biomechanically, that actually makes more sense because you're trying to get cortical bone to cortical bone. So if you're trying to compress cortical bone, then it seems like you should have your compression vector in that same, like across the joint, as opposed to if you're just parallel to the pelvic floor, you're not.
Absolutely, it makes sense. Let me show you why. Because now, first of all, medial to lateral. Let's say this is the sacroiliac joint here. Medial to lateral, you put something there. Imagine you want to put a screw and connect them together like that. In a true lateral to medial, your screw look like that. In a perpendicular to the joint, your screw look like this. This is the difference. That is very trivial. Okay. So, but you know, Sam, I think if you don't mind, we can get together. Actually, Mitch, let's make it a podcast. Let's actually make a podcast about the techniques, plural, of the sacroiliac joint fusion. Then we will talk about all the techniques. Can you talk to Amanda and Alyssa? And let's do an essence of medicine techniques of the sacroiliac joint fusion. Then we talk about the open technique, how it's historically have been done. I have used like probably 8 different systems.
Jeez.
And I have used anything you can imagine. I have done it with the scoliosis, where you spend literally 2 hours and lose 1,500 cc of blood just for sacroiliac joint fusion part of it. And I have done, you know, medial to lateral, lateral to medial, true lateral to medial. I have done 5 different perpendicular to side joints. So, but let's set up at the meeting at Mitch. Talk about all the techniques of the sacroiliac joint fusion, okay? So
I'll send you a message now. Thank you.
Yeah, that would be as well valuable for you. Now, again, you know, I really apologize. I have been way too ambitious here. So I have put 120 pictures here, and now we are by the picture number 4, and it's already 10:53. So let's go over a few things. Mitch, What is that white inside of the, what is that?
Basically just a gaseous space.
Gaseous space. How does a gas come inside of the disk?
It's the decay of the material inside there.
Very good. What is
Is that-
that? If you sample that gas, what does it end up to be?
Oh, this is a good one.
Nitrogen and CO2.
Excellent, excellent. How so? Why?
I think the degeneration of the, I would think the cartilage inside would just like go like into combustion and give you the nitrogen and CO2 with oxygen.
Yeah, well, there are three kind of gases in our body, right? The gas that we inhale, right, or swallow, which is air, which is the outside air. Number two is the gas of the bacterial decay, which is mostly methane and sulfuric compounds and so on and so forth. And there is a third gas in our body, the degenerative gas, where something non-bacterially decomposing and releases the gas. Now, I'm not sure, guys, if you guys ever in the school, they put you through how they produce ammoniac, right? Ammoniac, it used to be extremely, they used to take the pee of people as a fertilizer because it is so valuable. And it was impossible to combine nitrogen with other things because nitrogen is an inert gas. It doesn't want to be combined with everything else. You have to put it under 300, 400 pressure of atmospheric pressure to combine it high heat, like 700 Celsius or so, to combine it with other compounds. So what that means, all the nitrogen in our body, in the protein, if you give it a chance, it'd rather be alone than not. So what does that mean? Meaning you have a piece of cartilage in your joint, in your disc, in your facet, and they're grinding each other. You put a bag of meat under the sun outside, it's a sterile. It's all sterile, but you put it outside, just the energy of the sun's ray, it knocks out the nitrogen out of its bound with the protein, and it releases that. So the degenerative gases in our body is about 95% nitrogen that is released from the mechanically decomposing, not the bacterial cartilage. And then there are some other compounds like CO2 and so on, but mostly nitrogen. They have done that. Once you sample it, and by the way, there is a reason we call it vacuum effect. Because sometimes in certain situations, when they put a needle to take it out, actually what you were talking about, Scott, that hiss, it actually, sometimes it comes out, sometimes depending on the position, it goes in.
For a discogram too, if I see that and I'm doing a discogram and I access that, that white spot, I'll know that I'm in the nucleus pulposus, or where the nucleus pulposus should be.
Exactly.
You'll hear it.
That's actually one of the pictures I want to show you with the discogram, that literally that is always a pathologic sign. If you see vacuum effect, we call it vacuum effect, is 99% of the time it's not a vacuum effect, it's a nitrogen, but it's always a pathologic sign, and you see it in the facet, you see it in the disc, you see it in the sacroiliac joint.
Yep.
Okay. Now, I wanted, since we don't have much time, I do want to show you two things which are related. One is actually the discogram. The second is what we call anatomic decompression, or indirect decompression, which I call anatomic physiologic decompression. Now, look at that here. I'm about to go in and start already sucking in some air right here. And now, once I'm in, see that white getting bigger? That's air coming from outside. Now, this is not vacuum effect. This is me distracting the position, that location, and then increasing the place, and then there is a hole inside of that dilator, and that sucks the air in, and that's what you see there.
Nice.
So what that means that the distance between the two discs track, air gets sucked in. By the way, if you compare this and that, have added about 4.5, 5 millimeter interdiscal space. Once at 2.5 millimeter, we have done that. I can't show you the math of it, but once in an average person, once you add 2.5 millimeter to the interdiscal space and so 2.5 millimeter to the interpedicular space, you're doubling the area of the lateral recess and foramen. Because again, it grows not by
It's very
linearly,
nice.
but exponentially.
I didn't know that actually. 2.5 millimeter, and you double the foramen, so that's for the indirect. That's interesting.
Yeah, and we call it anatomic physiological decompression. Why? Because in the nature, when you're born, you're not born with the foraminal stenosis, right? Or some people are, but I mean, 99.99 times people are not born with the foraminal stenosis or lateral recess stenosis. That's something you acquire later in life. And 9 out of 10 times, the reason for that is collapse of the disc. 1 on 10 times is actually that flavum or facet grows, but as well, flavum and facet grows because they're stressed out. If the disc is not competent, it put too much stress there, then they grow and make it smaller. Now, we are just restoring the disc height to what it used to be. We are restoring the anatomy and physiology, and that is how it literally gets rid of the foraminal stenosis. But let's put that. Let's put the theoretical part aside. The fact is, I have over 200 patient testimonial, or almost every single person of them, they wake up and they tell me the leg pain is gone. So the rest is just brain fart for me. If the patient wake up and they say the leg pain is gone, that's all matters to me. But once you go and look at that, you only need, and that is why one of my mistake was I was overstretching
correcting.
Correcting it.
So wait, what's that number again? You get a 2.5 millimeter height.
In an average person, average anatomy, 2.5 millimeter distraction of the interpedicular space, and most of the time, if you distract about 2.5 millimeter the interdiscal space, you are distracting 2.5 millimeter the interpedicular space. That doubles the area of the foramen and lateral recess.
Well, the doubles the lateral recess. That's interesting.
Yeah. Just draw a thing in the. Just take an average. What do you think the average thing is from one of your models? Do it, and then add 2.5 millimeter to the to the diameter of that thing, and then do the calculation.
So,
but don't take a normal model. Take a model that considering that foramen is really narrowed. Like put the bone on bone, see what that foramen look like, then add 2.5 millimeter and do the calculation.
So how much do you have to get it to look different radiographically? I mean, because radiographically, I feel like indirect
that is the measurement I did radiographically.
Okay.
This is the radiographic. No, but you have to use a high resolution fine cut CT. You cannot use an MRI for this.
Okay, that's the key. Because I mean, yeah, I think my perception is that spine surgeons really hang their hat on how their CT scan or their MRI looks pre, like direct decompression, laminectomy with posterior fusion versus post. And they look, I mean, the canal looks beautiful, but then there's all that scar tissue above, and the patient's like recovering for 4 months. And then they come back to me, the pain clinic with still pain.
Well, the beauty of what I do is I'm not through foramen. So meaning that I don't have that scarring from the foramen and so on. So I'm outside of the foramen. Now, Farbod, do you want to describe to us what is the advantage and disadvantage of MRI versus CT for foraminal and lateral recess diagnostic? I mean, how do you use it in your hand? And as well, maybe if Dr. Zager is with us, how do you guys use it differently? MRI versus the CT for diagnostic of foraminal and lateral recess stenosis?
Yeah, so I think, for the MRI is a better study for stenosis as far as looking at the nerve and the CSF.
Because you see as well the soft tissue.
Yeah.
Because your stenosis doesn't need to be osteogenic. It can be a soft tissue. Go ahead. Yes, absolutely right. Go ahead.
Yeah, so basically I kind of look at the foramen on the T1 sequence on the sagittal view and look for, like the fatty, bright signal around the nerve to see how.
Fat as indicator, because if there is fat is the first thing to go. No, CSF is first thing to go. Fat is the second thing to go. But in the sleeve of the foramen, it is not really much CSF. You cannot use it. But the fat in the lateral recess and foramen, mostly foramen, is the first thing to go. Go ahead, please, Herbert. What else?
Yeah, so that's how I kind of look at foraminal stenosis. But then lateral recess, I look at the axial view and kind of combine it with the sagittal view. And look at the T2 sequence and look at the lateral recess and just follow the nerve roots and see if they're getting pinched. But
Sam, what's your algorithm to evaluate lateral recess foraminal stenosis? What do you do?
Yeah, so for foraminal stenosis, I really like the T1 sagittal views to see the fat. And I also like the CT scan because the CT scan sometimes can show you the up-down foraminal stenosis, like from the osteophytes. Sometimes I think it's useful in case we're thinking about just doing a direct foraminal decompression there. And for the lateral recess stenosis, basically, as it was described, basically, I like the MRI T2 cut and
absolutely. Now,
can I ask you, when you say CT scan, are you talking about a CT myelogram or CT without?
You're taking my point away, Scott.
Oh, I'm sorry. I didn't know. I wasn't trying to take your punchline.
I love it. So,
but at least I'm thinking along the same lines.
So, absolutely. So, see, traditionally, they just describe that the good way, that the best way of doing that without the needle, putting a needle in the patient. You look at the T1. The T1, the fat is white. You see it around the nerve. Sometimes you can even see the nerve, which is dark in the fat.
Okay.
Now, why not do it all the time? Number one, what is the resolution of MRI? As a matter of fact, I have an album on my Facebook, explain the physics of it. For God's sake, I'm telling, if you like, the ABC of medicine is anatomy. If you don't know anatomy, you cannot do medicine, no matter what you do. The ABC of imaging is physics. If you don't know the physics, you don't know how to interpret this now. MRI. You have a beautiful MRI. What if I told you 90% of what you see on your screen is made up data, it's not actual data? Because the actual data of MRI is 256 times 256. Go watch one of those old movies on VHS, on video cassettes. Now reduce that by 1/8. That is the actual resolution of an MRI, which is 256 times 256. So
it doesn't depend on the Tesla, like 1.5 or 3.
It does. Like, no, the physics. I love it. Hey, Sam, you and we should do a physics of medical imaging podcast together. You go do research, and then we come on a podcast. Farbod, I invite you to join that as well. We should do the physics of medical imaging. Now, I had a 0.2 Tesla magnet. It would give me beautiful picture, but it would take me 45 minutes for just one series. If you have a 0.5 Tesla, you can do it in about 25 minutes. If you have 1.5 Tesla, you can do it in 15 minutes. If you have a 3 Tesla magnet, you can do it in almost 3.5 minutes. You can do a beautiful picture, but the beautiful picture of the MRI standard is 256 times 256 grid. The high resolution MRI then takes 4 times longer. It is 512 times 512. And the thickness of the slides is in MRI is, if you're lucky, you get a 3 millimeter slide. 3 millimeter. Everything in there, you get the average signal of a qubit, which is 3 times 3 millimeter. Okay? So anything below 5 millimeter, everything is fuzzy, but you don't like fuzzy pixelated picture on your screen. So I wrote for God's sake, those algorithms for the neuronavigation that we did, because in neuronavigation, you get the axial CT and you make the recons and so on and so forth. And then those pixelated people hate that. So we invent points between them to just make them up. So what does that mean? If you're looking at a beautiful MRI in certain view, and you see a crisp edge of the bone and the edge of the nerve and so on and so forth, 90% of that is in your head. It's not the real data, okay? Now, let's go back to CT. CT, the standard CT is 512 times 512. Now, do we have a mathematician here? If you go from 256 and you double it, you go to 512 times 512. How is your density is affected by that? The density of data, is it twice as much? No, it is 4 times more. So average CT has 4 times the density of the data than average MRI, and it gets even worse. If you know how the physics of the MRI works, then you understand why you cannot measure the distances accurately in MRI. It just doesn't work that way. It is, if the MRI says it's 1 millimeter, it could be 2 millimeter, it could be 0.3 millimeter, because there's a lot of spatial distortion, and you understand that if you understand now CT as well has spatial distortion, but is much like 1/10, 1/20th of MRI. So meaning this distances measurements are way more accurate, not only because the data density is 4 times more in a standard view, but as well is that the spatial distortion or artifact is much 1/20th of MRI. Now, the problem is that the soft tissue are not very visible on the CT. Hence, you cannot see if it's a flavum is pushing on something, or is it some other soft tissue is pushing on the nerve and so on, except you put contrast in the CSF, then the lack of contrast can give you a good indication if there is a soft tissue stenosis there or not. Hence, in inspired spine, or for me, my preference, number one, no patient of us gets surgery without the CT, because you think something is, soft tissue, you show up there in the surgery is bone, and you make a huge difference.
From the MRI, you think it's soft tissue, but it's actually bone.
You think it's maybe flavum, you go there, it's not flavum. And number two, the measurements, I don't rely on MRI for any of my measurements, or trajectory, as a matter of fact. But so in our protocol, everybody who get a fusion get a CT, number one. Number two is that by using a little bit of a contrast, HCC of Omnipath 240, I get almost all the data, except if you are going to do tumor or extraforaminal things where CSF doesn't get there. Now, and then you see in the regular old-fashioned myelogram, you see that Christmas tree, that you see if the contrast goes along the nerve root, then you see in a regular CT, in a regular myelogram, you see if all of a sudden something is cutting off one of the axilla of the nerve, and then in the CT, you can actually almost get all the information MRI can give you, and way more, except if you're dealing with intrathecal pathologies like tumors and so on. Then MRI is obviously the best thing you can do. But for most of the thing we do, if I can.
What about alternative, like a PET scan? Is MRI versus PET scan for like tumor better, or just enhance, or the MRI plus the PET scan is necessary?
Sam and Farbot, what do you think about? We are talking specifically about tumor, right? That's what we are talking about.
Yeah, well, I mean, there's a rationale for this. I'll tell you when you tell me the answer.
Well, you see, you remember I told you MRI grid is 256 times 256. There is no way they can make the PET for you so that you don't see the pixels. The resolution is so poor that that's why you get, when you get a PET scan, you always see the pixelation of it. But it is very powerful for certain situations. Sam, where is the PET scan is very, very powerful. Why do we even do it?
I mean, if you want to just sometimes they do like the study to see if there's like arthritis in the facet or something that lightens up. That's bony anatomy. I mean, for me, particularly in metastasis, as a surgeon, doesn't really add much because it doesn't, as a surgeon, I want to resect the tumor or manage the tumor. I wouldn't actually be able to know how I'm going to approach it based on a PET scan, just based on something.
The MRI would be standard. Okay.
Yeah. Fabo, did you ever use PET scan for any of your diagnostic?
I really don't use it much, but I know that sometimes in a case that's a little bit tough, it could, because it's all about metabolic uptake, PET scan. So sometimes it could be related to a pain generator if a joint is symptomatic, but typically, for a tumor case, it just shows you the uptake and, can maybe show you lesions that are smaller that you might miss on other stuff. And it can kind of give you a more global image of the body, more, but in my practice, I've never used it for surgical planning.
So let me tell you again, I'm so looking forward to do our podcast, the physics of medical imaging, because what is PET scan? You have a special kind of glucose that some of the molecules are radioactive, they decay, and they send an electron on one end and a positron on the other end, and the detectors detect them and say, where should that be originated? So you are looking for very, very active tissue. What is the very, very active tissue? Inflammation, tumor. And let's go back a little. Now, how do you know it's normal or not? The best way you have seen this being put in use is like you have a tumor, you resect the tumor, then everything goes dark. You have a PET scan before you resect the tumor, you see how that tumor is reacting, then you resect the tumor, then that area is dark, meaning no more uptake, higher uptake. Then 6 months later, a year later, you go and get another PET scan and see, oh, something appeared again. Tumor recurrence. Regarding the degenerative changes, mostly in the rheumatoid arthritis and other autoimmune disease, where your body is going crazy, having a lot of activity where it should not have activity. Again, you get it, it's that joint shows up, it's very, very active. You give them gold particle methotrexate, you give them whatever, it goes dark. And then you want to see, can I stop it or not? Then what do? You just get serial PET scan while you are going up and down with your medication to see if you're going down. It is a very good, very, very sensitive to see if tumor is coming back or inflammation is coming back based on the treatment you're providing or not. But for us to put a screw in to fuse it or not, some people do use that. As a matter of fact, they think, if in question, get a PET scan or spectral scan, which works not the same but similar. But it has not been very useful tool for my thing. But you wanted to say something about it, Scott. Why don't you go and say why you were asking that question?
Oh, I mean, we because in what I call the stim wars in our field, where there's stimulator devices, there's one company in particular that has a device that, regardless of how the conductivity of the wires, if there's like a fracture in the wire or something, the patient can get an MRI, and they market that very heavily, but they have some efficacy, but they also require recharging. The other two major players, the other three major players, if there's some sort of fracture in the wire, then the device cannot go into what's called MRI mode. And one of the companies that we use, I feel like a lot of patients have, they like it because it doesn't have to be recharged. They just use it for 6 years and it doesn't have to be recharged. But the downside is if there is a fracture, which can occur over time, just the wires, they just over bending over and over, they just lose, they get what's called a high impedance, and then they have to be explanted to do an MRI. And before like 2012, none of the spinal cord stimulator systems were MRI compatible, and spine surgeons just relied on CT scans, probably for the reasons that you just articulated. But these days, MRI is sort of asked for and almost seen as a standard of care for a patient to be able to have ongoing care for back pain. And I think there are certain conditions that you absolutely have to have MRIs these days. Breast cancer is now screened with MRI, but so I'm trying to figure out is, do I ask a patient, do I emphasize with a patient the importance of not having to have a device explanted so they can have an MRI if their back continues to degenerate? Or do I say, yeah, it would be really nice to not have to recharge this device continuously, but the device is functional because it has a little short in it. We can't put it in MRI mode, but you could still get a CT scan. And that would be, in most cases, sufficient for ongoing
Tracy, how are you?
back pain.
Good to see you. I can open up the
This
video
is,
call
I'm
here. I'm
just
on
going
mute.
to, this doesn't, so slow. Oh, this is so slow to respond. I apologize. This is a podcast we did. We did about artificial disc versus fusion. This is a very famous, by the way, influencer in medicine, in the spine, Dr. Joel Kim. He's pretty famous. Now, we talk about the artificial disc versus fusion, but there as well, we discuss about some of the things, Scott, you were talking about, including discogenic pain. One of the reasons PET scan SPECT has been used is for discitis, to see if there is activity inside of the disc. But some people have suggested, why don't we use it as well to see if there is a discogenic pain? And for discogenic pain, what you guys do, David, Scott, discogram, I think is way more powerful. And if you listen to that podcast, we discussed in that podcast, okay, discogenic pain, does it exist, does it not exist? I'm not going to go there because that is one of the best podcasts we have done. And we have like, I think 60, 70,000, or maybe 100,000 views on that podcast already, even though it was just 6 weeks ago. That is a good podcast. And Dr. Kim explains, why he does believe in discogenic pain, because some of us surgeons, we don't. And now,
I think it exists for sure.
Well, that is, I'm a total believer in that. But if you go to conferences, lots of academic spine people, they dispute that discogenic pain even exists. But that is a different story. But if you believe in discogenic pain, I think better than spectrogram, PET, or any other radionuclide kind of study, discogram is the best. And here, I just want to show you double cushion appearance of a regular disc versus when the material of the disc literally fills out and the patient has concordant pain. That is what I think is much better study. That is probably why I never use any of those radionuclide study. But I think it's I could go on and on, but it's 12:22 here in Florida. It's 11:22 in our place. I like to stay right here, and I don't want to overstress your time, guys. So, but I'm really looking forward. If you guys want to join me, Farbod and Sarmat, and Sam, if we can do the physics of medical imaging, we can do that together. And Mitch, you are going to set us as well up about essence of medicine, the techniques of sacroiliac joint fusion.
Yes, sir.
So any comment, question, or anything else you guys want to know? Anything burning you want to know?
Ask this is, I know you've already over time, but I want to ask one question. We've asked this before in the past, but we have a patient, and it was actually a patient I did an SI joint fusion on, not related to the SI joint fusion, but also has an intrathecal pain pump and persistent CSF leak. And we've revised like 3-4 times. How many times have we done that, Dave? Like 4 times for Nyla?
Yeah, 3 or 4. We're just oversewing the supraspinous tissues interfusion area, and she keeps leaking CSF somewhere in there. Super
So
hard to
can
tell
you
from
describe the situation? So patient had a previous fusion.
multiple lumbar fusions, lots of posterior hardware, had a pain pump for many years, doing okay. And then she started developing this CSF collection in the lumbar region that we could palpate. We tapped it, was definitely CSF. We went in there, opened it up, no leaks in the catheter. We just oversewed the heck out of it with big old Ethibond vertical mattress sutures, to try to tamp down the supraspinous tissues. And worked for a few weeks, and CSF came back. We did that a couple more times, and it just keeps coming back. So we're kind of stuck.
You'll remember this patient because I sent her to you after SI joint fusion. She developed CRPS. She was kind of a challenging patient, but what we discovered, her significant postoperative pain was because her intrathecal pump wasn't working properly. And after we revised it, then we got this persistent CSF leak that's now 2 years old, I think.
Yeah. No, okay. Well, no, that is too important. Let's talk maybe 5 minutes. Whoever has to go, please don't feel that you have to stay, but I think we should discuss that because this has many impact on patient care. Number one, Sam, how do you know for sure if it's CSF or not? What's the study that are basic standard tests to be sure it's CSF and not a seroma or something else?
We can tap it and send it for labs, basically.
What lab are you going to send it for?
The beta
transferrin.
Beta transferrin. So that sort of is so sensitive. So not everything that look like CSF is CSF. They're not as good as that as in sensitivity. You can put contrast in the CSF space, wait, not right away. Wait half an hour, and get a CT. Then you see if the density changes in that fluid. You get it early on, you get it after an hour or so, you see. So now, in a regular surgery, we go all the way to the bone, we cut the bone, we create a cavity, and sometimes that cavity is hard for that to fill. So it's not unusual to have what you're describing is a pseudomeningocele. That's what you're describing, correct?
Yeah.
They can be very nasty, and they can be hard to deal with, and especially if you have a situation that space just doesn't score, and sometimes if you're lucky,
and we have a tube there, we have a catheter going in.
It's leaking around the catheter, right?
We can't tell.
But perhaps.
Okay, but you see that's the thing. If the tube goes through a lots of tissue to go to that space, then there are lots of tissue to tamponate it. But if it has to go through a cavity to go there, there's really nothing to tamponate that tube. So it makes sense that it's a higher rate of. That is one of the advantage that what I stay away from posterior element completely. So that the rate of what we call durotomy in a regular surgery up to 7.8%. Sometimes some studies say the rate of durotomy in our cases is 0. We haven't had a single durotomy after 1,600 cases now. So now the question is, for this patient, what do you do with the persistent dural leak? That is the question, correct?
Right.
Yeah, I mean, one thought I had thought of is, it's hard because she's getting medicine through her catheter, right? That's why we placed it for pain, for post laminectomy pain. But if you just transition her to orals and take out the catheter and then see if it heals, would that?
Yeah. Well, I can tell you the 3
else?
rules of neurosurgery for closure of dural leak. Sam, what are the 3 rules of neurosurgery for closure of dural leak?
I mean, I mean, I'm not sure aware of the rules, but I would do a primary repair if I can.
Number one, primary repair. Number two,
Patching.
primary repair. Number three, primary repair. The three
Well, I
rules
like
of
that.
neural
Fine.
leak is the three rules of the neural leak repair is primary repair.
So how many do you mean you get down and you visualize the dura and you sew it closed?
Exactly as Sam said. Yeah.
Yeah.
You know, I think, Sam, after 30 years, I know all those three rules. You're just early in your career, you only know the first rule.
I experience them every week. I
So the
repair
three
every
rules,
week.
so meaning that everything else you do, we tried it, it just didn't work. Now, having said that, yes, patient need the thing, but I just told you the three rules of dural repair. So what that means is, you know, you repair it, put that catheter somewhere where there is not much scarring. Stay away from that area. If you're lucky, if you're very, very lucky, that, you know, you can just fill that space with maybe fibrin glue or or blood patch and so on. If you're very, very lucky, that will close. But the three rules of dural leak repair is primary repair, primary repair, primary repair. Okay.
So
There's one case where we ended up, and now I'm gonna sound crazy, Dr. Abbasi, like pediatric neurosurgeon. We ended up doing a shunt.
Uh-huh.
Well, we talked about that in another patient a couple years ago, Ricky.
Okay.
But I wonder how
And
the shunt would work with the intrathecal medication. Then, like, we're taking them out and putting them back in the abdomen, or how the
it wouldn't be dangerous, but if you were going to repair CSF, they'd be in the ICU with a lumbar drain, right? On very
Depending on the
watch very
situation.
closely.
Depending on the situation. I mean, if you cannot do a direct repair, primary repair, then you want to divert, reduce the pressure. And then if you're relying on anything else but primary repair, like I do a lot of spinal tumor, we do cranial thing all the time. If you have a good primary repair, you don't have to put a drain or put them in the ICU. But for pituitary, I used to do a lot of transvenoidal pituitary. If you have a dural leak there, you cannot really do a primary repair there. It's hard.
and
So what you do, fat, muscle, and then you put the lumbar drain to reduce the pressure while you're going through your body is repairing the leak up there. So the lumbar drain are good option if primary repair cannot be achieved.
But I think
Well,
a primary repair is going to necessitate removing the catheter that's there. Right?
yeah, probably find.
I mean, we're just gonna have to tell her that we have to probably transition to orals and then fix it, and then I don't know.
Now you see the frustration of surgeon who have to put like pituitary tumor, posterior fossa. Oh my God, the posterior fossa, they're horrible. Now you're just feeling a little of the frustration, everyday frustration of a neurosurgeon. Scott, welcome to our crowd.
Yaris, like they would never get better and always complain of meningitis.
Yeah. And then they come for years and then they get infected on and off and so on. So let me tell you something that's the dirty secret of spine surgeon or neurosurgeon. Until not long ago, half of our patients would die if we would touch them, if we do surgery. That wasn't long ago. Like I'm talking about 50 years ago. One of our father of neurosurgery, his name is what? Sam, father of neurosurgery. Do you know why Harvey Cushing is Harvey Cushing? For the first time, not all his patients died after neurosurgery. Not all, repeat that like a hymn. Wow. He's a father of neurosurgery because not all his patients died after neurosurgery.
All of his patients died.
Okay, so Scott, welcome. Now, okay, I think we just leave it there. Okay.
So Hamid, you'll be happy to know we sent this patient to your colleague, Dr. Samadani.
Okay. Good.
We didn't want to burden you.
Dr. Samadani is very good at that. So now Coming back, like you remember, we talked about that BMI patient 51, 52. We did the L3 plus 1 OLLIF university. The anesthesiologist told the patient, hell no, this is not a 1.5 hour surgery. This is an 8 to 12 hour surgery, 4 days ICU stay, 2 weeks hospital stay. Now, we did the surgery and I see Nick's report on that. L3 plus 1 OLLIF, 74 minutes and 102 cc of blood loss. Patient was discharged 2 days ago. She could have gone home next day, but she had to travel from Crookston to the cities, which is about 300 miles. So that is the reason we kept her one more night in the hospital. She could have gone home next day after the surgery. And that is the impact we make every day. That is why patients come to us from entire United States, because we made a University of Minnesota 8 to 12 hour surgery in 74 minutes. We did something that's a half a gallon of blood loss. We did it with 102 cc of blood loss. We did a 4-day ICU stay and 2 weeks hospital stay. Actually, more or less a 1 night hospital stay. But this patient, I kept it because I didn't want to, in the afternoon of the next day, send them back on a 6-hour trip back to the cities.
Comparing like 12-hour surgery to a 74-minute surgery, like that's the best thing, to prevent infections, especially in that's like the best indirect, cost reduction that you can see.
No, just the idea that having that tissue all open and not huge incision, multiple small incision, having it open for 8 hours versus 1.5 hours.
Yeah,
and that is why the rate of infection in this kind of patient, high BMI, is not 3 to 5%. It's not your usual 3 to 5%. It is 15 to 25%. But our rate of infection in this patient even is 0.3%. That is the difference. That is why we can do it. Okay. And what I'm really proud of is not that I do that surgery in 1.5 hours. Everybody who joins us does it in the same time period. It's a technique. I have to convince my colleagues that it is not my superior skills. I have more numbers, but everybody who follows those steps perform the same way. Okay. So it's a really good, I'm really proud of that I can package the knowledge.
I think that's a nice thing about being like in medicine in this era, interventional medicine of any kind, is that the engineering of the tools that we now have in our hands make things like an SI joint fusion that was a medial to lateral approach with huge blood loss, accessible to perhaps even a pain physician with some surgical skills and can do it safely and effectively and maybe treat more patients because we end up seeing them more frequently.
Scott, let me tell you why lots of surgeons are so hysterical. People like you helping the patient. They're hysterical because the surgery that they do in 5 hours, you do in 30 minutes, 40 minutes, because you're willing to use new tools, new techniques. They come out of residency, they're done learning. They never look back. So whatever they do, it was top of the line 40 years ago, 30 years ago, whereas you're willing to keep learning. So, and in Bio is coming to us, right? I hope you know what amount of shit surgeons are giving him for what he does.
I know. Believe me, I know.
No, but the fact is the same surgeon, they see a patient, they just walk away. Literally, they go into the room, they look at the big patient, they physically, they walk away.
And then they send him to pain.
And then they criticize BL for helping that patient. So it is what it is, and we are where we are. But if you are willing, no matter where you are, if you are willing to learn and move forward, you will make everybody around yourself irrelevant.
Dr. Abbasi, that's the problem, basically, of academic. I'll be honest with you, academic medicine, organized neurosurgery, because that's, where where all the decisions come from. Like, you know, if you read like statements from the WNS or guidelines, sometimes, you know, they just don't make any sense for a rural neurosurgeon or somebody that doesn't practice in a big institution. But this is what they want to impose, because there was a slide in my MBA, I guess I remember, like people who shout loudest, you know, get heard the most. Basically, at the end of it, doesn't matter talking about logic or something like that. And unfortunately, most of these people, as you said, like practice like 40, like they're still stuck with what they learned 40 years ago, but they have the posts in their organized institutions, and that's why we, like, medicine is the slowest probably to progress.
But Sam, you are in the most exciting time of medicine. Do you know why?
Why?
Patient look you up.
That's true.
Patient look you up, and I get a lot of shit because of the things, my social media and the things I do. And let me be very clear. Even internally, like, you know, when I started putting my data out there and my persona, out there and so on, I get a lots of, you know, God bless his heart, Sudhir is a great man. He's a great visionary and so on. But, you know, he thought I'm crazy to have social media, put my things out there, because that is not what you do. Well, that is not what you do in a traditional sense of medicine, which is governed by few old farts that they just say what it is and they cannot even back it up. Everything has changed. They still do that. Now, but patients are true beneficiary of what you guys do. Okay, then patients have internet, they have social media, they look you up. It is 2024, and I would say just be open and just put your results out there. Patient will look you up, and then when patient know you, you are independent of this big system and university. And you know, that's the reason I'm not in academics, Sam. You know, I could not, when I was starting my medical school and my residency, I could not imagine not to be in academic. I could not imagine not to be an academic. When I was done, there was no way I could imagine myself in academic, because it wasn't really, academic wasn't about really innovation. It wasn't about moving things forward. For God's sake, it wasn't even about patient care. It's about how fast you can get to your tenure.
Honestly, it's about politics, not innovation. Not, it's just like do what I say. That's like, I mean, unfortunately, because I'm the same thing. I really wanted academic from the beginning. I like to learn, I like to teach, but definitely not my thing.
Well, you know, do what as I say. That is, now we did a podcast about the life of Ignaz Semmelweis. It's a podcast. You should listen to that, because that summarized academic medicine in 1800 in Vienna, in Austro-Hungarian Empire, and that summarized the academic medicine in 2024 in United States. Do as I say. I don't need, this is what the professor of Ignaz Semmelweis told Ignaz Semmelweis in 1870 something. I have no need for people who thinks. I just need people who do what I say. Do you know what Ignaz Semmelweis said? When you go to cadaver lab and put your hand in the body of the woman who have died of puerperal fever, wash your hand before you go examine a new patient. That is what he said. About more than half of the people, women who would go to Vienna hospital would die of puerperal fever. And Ignaz Semmelweis says, after you're done in the cadaver lab, wash your hand in this lime before you go examine new patient. And his professor said, I don't need radical ideas. I don't need free thinkers. I just need people who follow. If you want to make a career in medicine, Dr. Semmelweis, you do as I say. This is not a joke. I'm not making this up. And you would be surprised to know it is not much different now. Okay? So, but that is philosophical. That's not case conference anymore. But I did a podcast about that. It's called the Remember Ignaz Semmelweis, Essence of History. Remember Ignaz Semmelweis. Well, thank you guys. You have been
All
really
right.
good now, okay? Okay, thank you. Bye-bye.
Thanks, everybody.
Sam,
Bye.
Thank
I'm
you.
looking forward to do